Hello everyone. So today's topic of discussion is radiology of upper aero digestive tract. We'll be going through the topic under the following subheadings. We'll see brief introduction on what is an upper aero digestive tract, then what is barium swallow study, video fluoroscopic study, and lastly we'll discuss briefly about foreign bodies in the aerodigestive tract. What is aerodigestive tract? As far as the aero part is concerned, it potentially includes all structures from the nose and mouth down to the alveoli of the lungs. As far as the digestive tract is concerned, it is usually limited to the structures that are proximal to the gastroesophageal junction. So, oral cavity, nasal cavity, the paranasal sinuses, the pharynx, which includes the naso, oro, and pharyngolarynx, the larynx, and the proximal esophagus. So, you can see the following structures in the image. When do we need imaging? So the most common symptom that we have is of obstruction. That obstruction can be in the airway or it can be in the digestive tract. So airway, the obstructive symptoms appear in when there are foreign bodies, when inflammatory disorders are there, in cases of cervical trauma, in cases of neoplasia, and in cases of voice disorders. In the digestive tract, obstructive symptoms can be seen in foreign bodies, in cases of choking, in neoplastic conditions, in with a person with any swallowing difficulty, or a person with any neurological disorder. So, what are the armamentarium of radiological tools that we have with us? We have roentograms, which can further be modified to get a barium swallow study or a video fluoroscopic study. We can have ultrasonography. We can have computed tomography and magnetic resonance imaging, both plane and contrast studies. And then we have the positron emission tomography, computed tomography study with us. So, what is barium swallow? It is a contrast enhanced radiographic study to assess the anatomical and physiological characteristics of the esophagus. When do we do it? When the patient presents with the symptoms of dysphagia, weight loss, hematemesis, and in cases of post-operative status. The following images on the left, it shows a cross specimen of the hypopharynx and the esophagus, and on the right, it is an X-ray of the same cross specimen in an anteroposterior view. So why do we use barium for the studies? Because barium, it has a high attenuation for X-rays. It appears white on X-rays. Then it shows a clear visibility in the shadow of gas or air, which appears black. There is lack of absorption from the gut into the body, lack of toxicity, and it coats the wall of the gut, making the size and shape of the involved structure visible to us. What is the purpose of imaging? We can do imaging in cases of congenital anomalies, developmental abnormalities, in cases of functional, involutional, and degenerative disorders, in cases of organic lesions, which can either be local or systemic. In cases of systemic, we can have organic lesions like neuromuscular disorders, inflammatory lesions, granulomatous lesions, collagen diseases, deficiency disorders, leukemia, lymphomas of the esophagus, amyloidosis, esophageal varices. In local lesions, we can have esophageal ulcers, esophagitis, benign strictures, diverticular, and primary neoplasms of the hypopharynx and the esophagus. So, in all these cases, the patient will present with a chief complaint of dysphagia, which can be either sudden in onset or it can be gradual and progressive. It can be initially to solids and progresses to later to liquids, or to liquids initially and then it progresses to solids. So, how do we prepare a patient for a barium swallow study? So, we ask the patient to do an overnight fasting first, and before we start our barium swallow, we need to do a check fluoroscopy before giving any thick bolus to rule out any signs of aspiration pneumonia or to look for any radio opaque lesions. Now the patient will be put in supine position. Radio protective cover is put to prevent any harm to vital structures. Then the patient is put in an oblique position, most commonly the right anterior oblique position, and a thick bolus is given to see the esophageal peristalsis and to look for any motility disorders. The patient is positioned at an angle of 35 to 40 degree, and the X-rays are taken in multiple views and serial views. We take the X-rays in a lateral view and anteroposterior view to see the vallecula, the pyriform fossae, the dorsal part of the esophagus, and the gastroesophageal junction. Also, a particular position called the Wolf's position, which is you can see now, is done in cases of a gastroesophageal reflux disease and hiatus hernia, where the patient is prone, put in prone position, or either on the left or the right side, and is elevated by a radiolucent Wolf's stem, and the central ray is at 90 degrees to the spine. Or the patient can be put in a modified Trendelenburg position, as you can see in the image. So the most common position I told you was right anterior oblique. Here the esophagus is seen between the vertebral column and the mediastinum, and the extent of the esophagus that is visualized is from the root of the neck till its entry into the stomach. In this view, we should have proper collimation. The esophagus should be completely filled up with the barium, and there should be adequate penetration of the barium. Okay, if it is anteroposterior view, if the patient is not in an oblique position, then the esophagus is seen to superimpose on the cervical spine, which is not desirable. It should be on either side of the uh, cervical spine. The other common positions that we use in barium swallows is the lateral esophagogram. This is the swimmer's position. This position helps take out the shoulders from superimposing the upper cervical spine and the clavicle when we are viewing the upper esophagus. This is the left anterior oblique position. So, what are the phases of barium swallow? We have three phases of barium swallow. Phase one is full contrast phase. Here, we ask the patient to take 2 to 3 sips of barium liquid and quickly takes 2 to 3 swallows, so that a column of air is also swallowed with the contrast. In phase one, the barium bolus can be seen completely filling the esophagus. In phase 2, which is the double contrast phase, we see air column within the barium column. This helps to detect any mucosal abnormalities and any small lesions which otherwise may be missed in phase 1. And phase 1 shows any filling defects. If there is any tumor or mass lesion in the intraluminal compartment, it will show a filling defect. The phase 3, we can this is the mucosal phase. We can see three stripes of layers of the esophagus, and this is very important to delineate any tumor other than the intraluminal compartment if it is in the walls of the esophagus. But before we proceed on to reading, uh, look into the abnormal findings, we need to know what are the normal variations in a barium swallow. So usually we know that there are three normal constrictions or indentations which are not to be confused with any lesions that are causing constrictions. So the first one is by an indentation by the aorta. The second one is an indentation by the left bronchus, and the third one is an indentation by the left atrium. There is also a cricopharyngeal bar, which is seen normally in individuals as they grow older, and the chances of this incidental finding increases with increasing age. But it is more prominently seen in cases of motility disorders, which I'll show you right now. So here we can appreciate the vallecula and the lateral pharyngeal wall and the piriform fossae on the right hand side, and these spaces are enhanced by Valsalva maneuver or puff cheek maneuver. Now we'll go to the pathologies. First, the motility disorders. So the first image, we can see tertiary peristalsis in a lying down position, which indicates that the person has some motility disorder, which can be attributed to neuromuscular disorders or pseudobulbar or bulbar palsy. The second image shows anteriorly tertiary peristaltic movements with posteriorly an abnormal cricopharyngeal bar. The third image shows a Shatsky ring, which is a smooth circular membrane of mucosa and submucosa that forms at the squamo-columnar junction of the distal esophagus. And the other potential causes can be hiatus hernia, acid reflux, and these later lead to a condition called the Barrett's esophagus. On the left hand side, we can see Zenker's diverticulum, which is a pulsion diverticulum, and it is located at the pharyngoesophageal junction. And we need to understand that it appears above the cricopharyngeus muscle. So this is the cricopharyngeus muscle, this is the thyropharyngeus muscle, and it appears in an area of dehiscence between these two muscles, which is called the Killian's dehiscence, but it appears above the cricopharyngeus muscle, and we need to differentiate it from Killian-Jameson diverticulum, which is a traction diverticulum in the anterolateral wall of the proximal cervical esophagus, and it appears below the cricopharyngeus muscle. The second image, so before this is a video fluoroscopic study of Zenker's diverticulum. We can see in anteroposterior view that it appears a little onto the left of the esophagus, and in a lateral view it appears posterior to the esophagus. So this is the most common site of Zenker's diverticulum. So pharyngocele, it is normally found in some people with occupations where they have to uh, blow forcefully. For example, glass blowers, trumpet blowers. Okay, there is a lateral pharyngeal wall herniation through the pyriform fossa or the vallecula, and there is usually a common region of weakness where the vessels pierce in. So pharyngoceles, they appear to bulge from those recesses or areas. They are usually rare and they are more often unilateral than bilateral, and it appears usually in the 5th to 6th decade of life. Hiatus hernia, it occurs when the upper part of the stomach is pushed up into the chest through a small opening in the diaphragm, and this diaphragm usually is the borderline between chest and abdomen. As you can see that the hiatus hernia has occupied this retrocardiac space, and you can see an air fluid level behind the heart. So it is most commonly attributed to a hiatus hernia. The second image is of achalasia cardia, which is a motor disorder affecting the elderlies, usually in the age group of 30 to 50 years. There is degeneration of neurons in the oil bark plexus, which causes the failure of relaxation of the uh, esophagogastric junction. And there is an elevated resting lower esophageal sphincter pressure with a dilated proximal part. Sometimes it is also associated with Zenker's diverticulum or cricopharyngeal dysfunction, but it is important for us to differentiate it from secondary achalasia, which is seen in cases of carcinoma esophagus in older people. So this is a video fluoroscopic study of a patient with an achalasia cardia, where you can see a bird beak appearance. On the left hand side, you will see esophageal web. It is seen as a shelf-like lucency at the distal esophagus, and you can see a thin spurt of barium running through the stricture. It is most commonly associated with a condition called Plummer-Vinson syndrome, which is a classical triad of dysphagia, esophageal webs, and iron deficiency anemia. Here you can see a stricture developing and multiple swallowing attempts by the patient to pass on the food bolus. The image on the right shows a Killian-Jameson diverticula, which like I told you, originates in the anterolateral wall of the proximal cervical esophagus, and it appears below the cricopharyngeal bar. And this is only appreciated uh, in the frontal images, where it is seen overlapping the anterior wall of the cervical esophagus. So all these images are cases of carcinoma esophagus. In the first film, you can see that the mass is coated by the barium. The second one is in a case of advanced carcinoma esophagus, which has involved more than half of the esophagus. In the third image, you can see shouldering and proximal dilated segment, giving it a rat tail appearance, which I told is a secondary achalasia. Then, as we all know, that adenocarcinoma is the commonest carcinoma of the esophagus, followed by a squamous cell carcinoma. And the Barrett's esophagus, which is a pre-malignant condition, has a significant risk factor for developing adenocarcinoma, which is a risk factor of almost 30 times. The second picture is quite important, the image on the right. These images can be sometimes missed as a normal barium swallow, but we can see very early changes of mucosal irregularity, which may be missed out sometimes. All four images are of corrosive poisoning, which includes acids, alkalis, and oxidants. The acids cause coagulation necrosis and most commonly involves the antrum, as the squamous epithelium of the pharynx and proximal esophagus is relatively resistant to the acids. The alkalis, they cause liquefactive necrosis by saponification of the fats and involves the pharynx and the proximal esophagus more commonly. So the acids, they cause perforation usually in the third or the fourth day itself, but the alkalis, they cause perforation or stricture in the second to fourth week most commonly. So the first image on the left shows a smooth appearance of the stricture caused by corrosive poisoning. The second image shows a beaded appearance. The third image shows a complete stricture where the proximal segment is completely dilated and a very thin stream of barium can be seen. And the fourth image shows various sites of tracheoesophageal fistula post corrosive poisoning.